Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar session. Today's topic is Management of ARV Toxicities, and the speaker is Dr. Manaswi Chaubey. Dr. Manaswi Chaubey is an Associate Professor with the Department of General Medicine, Institute of Medical Sciences, Banaras, Hindu University, Varanasi. She is also the Deputy Program Director with the Center of Excellence, IMS BHU. She has done MBBS from MLB Medical College, Jhansi in 2010 and MD from SN Medical College, Agra in 2014. Her area of specialization is internal medicine and rheumatology. She is running a rheumatology OPD for the last 5 years. She has done EULAR online course for 2 years in rheumatology. She is also a member of the SASEP at COE. We welcome you, ma'am, for today's session and request you to start the session.
Thank you, Shweta, for the nice introduction. So today the talk is on management of ARV toxicity. So should we start now? Can we have?
Yes, ma'am.
Can I get my slides? Yeah.
Is the slide visible, ma'am?
I can just see the first slides only.
Okay. Give me 2 minutes, ma'am. Ma'am, is the slide visible?
It's visible also.
Is the slide visible, ma'am?
Yes. Just give me a second.
Yeah,
It's visible now. So today we are going to discuss about the toxicities of antiretroviral drugs. So we are going in this session, we are going to have first we will have an introduction of the topic. Then we are going to discuss in detail the DTG based toxicities. Then we will have we are going to discuss briefly the grading of drug toxicities and the drug substitution, and especially the guidance in the impaired renal function. Next slide. So when we talk about the drug toxicities of ARV, so it may be the class specific or it can be drug specific, and it might range from a low grade intolerance, which may be self-limiting, and in some time it can be life-threatening adverse reaction. One thing that you should always remember, and you should always try to differentiate the toxicities of ARVs with the complications of HIV, manifestation of new opportunistic infection, because sometimes your patient can have rashes, but that can be an oral candidiasis rather than a drug-related side effects. Now you have to differentiate it with the iris. So the patient can be having a paradoxical worsening of the disease, which you are mentioning it as an iris. As a drug toxicity, the patient can have some comorbid condition which is causing that manifestation, which you are labeling it as a drug related, or it can be secondary to concomitant medication. Next slide. Next slide, please. So when we talk about ARV toxicities, it can, as we know that we have NRTIs, NNRTIs, and integrase inhibitors, which we are using right now as a first line ARVs. So in nucleoside reverse transcriptase, that is NSRTI, which includes zidovudine, stamivudine, and lamivudine. So what we can just see is lipodystrophy and peripheral neuropathy was usually seen with the stavudine. So now we are not using stavudine. So what side effects which we can see is lactic acidosis and pancytopenia or macrocytic anemia, which we see with zidovudine. You can have a blue nail syndrome associated with zidovudine. And in some cases, you can find the patients with myopathies and pancreatitis. Now coming to the nucleotide reverse transcriptase inhibitor, that is tenofovir, you can have nephrotoxicities. Now integrase inhibitors, dolutegravir and raltegravir, they are relatively safer drug, but you can have weight gain and hepatotoxicity with the DTG based regimen, and raltegravir can cause rhabdomyolysis, or it can sometimes cause myalgia also. Now coming to the NNRTIs, that includes efavirenz and nevirapine. You can have skin rashes and hepatitis with nevirapine, and CNS manifestations are usually seen with efavirenz. Next slide, please. Now coming to the drug specific, so tenofovir can cause renal toxicity and it can cause bone demineralization leading to osteoporosis. Zidovudine, as we already discussed, that it can cause anemia, neutropenia, pancytopenia secondary to bone marrow suppression. In few cases, you can see the hyperpigmentation of the skin and nail in the form of blue nail syndrome. Lamivudine is relatively very safe drug, but very rarely it can cause rashes also. Now coming to the last drug, that is the abacavir. Now this drug which we use has shown to have certain hypersensitivity reaction in certain group of patients. So it is usually seen in less than 5% of adult and children in India, and is associated with the mutation in the HLA-B5701 gene, and it can be potentially fatal. Usually it is seen in the first 6 weeks of the therapy. And when you are sure that it is because of this drug, you should never introduce this drug again. Next slide, please. Now, efavirenz and nevirapine, because now we are not writing this drug, but still few patients, they are coming with the who are on this therapy, or they are coming to the OPDs. So you can, with the efavirenz, you can have CNS symptoms in the form of dizziness, insomnia, confusion, and hallucination. And rashes can occur, but less common than nevirapine. What you can just tell to your patient is that you should always take efavirenz. You should never take efavirenz after heavy meal, because fatty meal increases the absorption of this drug. So you should avoid taking efavirenz with after heavy fatty meals. Now coming to the nevirapine, it can cause hepatotoxicity. And that hepatotoxicity usually appears in first 12 weeks. And rarely it can cause Steven-Johnson syndrome or TEN, in which you should never re-challenge this, re-challenge the patient with this drug. Next slide, please. Now, coming to the protease inhibitor, that is atazanavir, ritonavir, and lopinavir, ritonavir combination. So atazanavir and ritonavir can cause hyperbilirubinemia. It is usually benign, and it doesn't need discontinuation of the drug until and unless if your bilirubin is more than 5 milligram per deciliter. It can cause lipid, that is problem, that is dyslipidemia, but it is lesser than lopinavir, ritonavir combination. Then you can have hyperglycemia, fat maldistribution, and nephrolithiasis. You can also have an ECG abnormality. So you should avoid giving these drugs, especially in the patient who is known to have arrhythmias. Now coming to the lopinavir, ritonavir, in addition to these side effects, lopinavir, ritonavir can cause an has a significant interaction with the statin group of drug, that is simvastatin, and it increases the simvastatin level in the blood and can cause rhabdomyolysis, leading to kidney failure. So you should avoid giving statin with the protease inhibitors. Next slide, please. Now, DTG and raltegravir. So DTG can cause hepatotoxicity, weight gain, and insomnia. In addition to this, raltegravir, what is unique, or what is the side effect which is not seen with the DTG, is that raltegravir can cause myalgia and rhabdomyolysis and myopathies, which is usually not seen in DTG. Next slide, please. So again, summarizing the common side effects. So zidovudine, as we already discussed, that it can cause bone marrow suppression and headache, nausea, vomiting. So most of the side effects of these drugs are short-term to mid-term toxicities, and they are not long-term. So only your stavudine was associated with the long-term side effects of lipodystrophy and dyslipidemia. So zidovudine, your lamivudine, and abacavir, they all cause short-term to mid-term toxicity. In zidovudine, you can have headache, nausea, vomiting. They are more or less self-limited. Macrocytic anemia you can get in zidovudine in patients on zidovudine. Then in lamivudine you can have skin rashes. Abacavir can cause hypersensitivity reaction, as we already discussed. Next slide, please. DTG and raltegravir, they can cause nausea, diarrhea, insomnia, rashes, and hepatotoxicity. Efavirenz, CNS abnormalities in the form of vivid dreams, skin rashes can be seen rarely with the efavirenz, and nevirapine can cause skin rashes with the hepatotoxicities. So more or less, the most of the toxicities of the drugs are short-term to mid-term toxicities. Next slide, please. Now there can be certain overlapping toxicities. So your patient might land up in bone marrow suppression, which you are thinking that it is ART related, but the concomitant drugs which you are prescribing can also lead to that toxicity. So if a patient bone marrow suppression can be either secondary to your cotrimazole that you are giving it for PCP prophylaxis. It might be related to dapsone or pyrimethamine or ganciclovir or amphotericin B or ribavirin related. Now, if patient is presenting to with the hepatotoxicity, look for the ATTs which can cause hepatotoxicity. So that can be isoniazid, rifampicin, pyrazinamide, your fluconazole which you are giving for preemptive therapy of cryptococcal meningitis, that can also cause hepatotoxicity. So be aware of that. Cotrimazole and DTG have also shown to cause hepatotoxicity. Peripheral neuropathy, as we don't use stavudine nowadays, so isoniazid related it can be, and pancreatitis you can also see with the cotrimoxazole. Next slide, please. Now coming to the DTG, DTG is the first line drug in India, and now it is being given to all the patients. A new patient and the older patients are also being shifted to the TLD based regimen. It has a good overall safety profile with a fewer metabolic side effects, and minor side effects including insomnia and GI intolerance have been seen in the initial phase of the starting of DTG. And in most of these patients, you need not to change to other regimen. The main concern with DTG was the neural tube defects in the fetus when used in the pregnancy and the weight gain. And the third was the hyperglycemia or diabetes, but the data are still limited about the diabetes and the weight gain. And for the neural tube defects, you have to do the proper counseling of the patient, because it has also shown that the incidence and the prevalence of NTD in the patients in the pregnant females who were on the DTG were as similar as other patients on other ART regimen. Next slide, please. Now coming to the previous slide. Can you just go to, yeah. So summarizing the side effects. So there was a study which was done in Brazil in year 2021, and it has shown, which included 72,000 patients, and it has shown that the most of the adverse events which are related with this drug were not serious. So, and they were limited to, and the most common side effect was nausea, diarrhea, and headache, followed by dizziness and insomnia. And only in 0.99% there was the adverse event caused the persistent or severe disability, and only 0.68% where 0.68% patient had their life at risk because of this drug. So more or less this drug is safer. Next slide, please. Now coming to the pregnancy with DTG. So with the newer studies, it has been shown that the risk of getting a neural tube defect in the patients using DTG based regimen at the time of conception is statistically insignificant as compared to the other regimen, and the incidence of neural tube defects is less than 0.2%. Other pregnancy outcomes, adverse pregnancy outcomes are also shown not to be increased in patients on DTG based regimen as compared to the efavirenz regimen. So this shows that the woman centered and the rights based approach should be followed, and all the females who wants to become pregnant, they should have an given up, they should be given a proper counseling, and they should take their decision about the correct choice of their ART regimen. Next slide, please. Now, the women of childbearing age should be provided appropriate information about benefit and the risk associated with the use of DTG-based regimen, and medical guidance should be given as according to their situation and supported with the informed choice. If a woman plans to become pregnant, you should always counsel your that lady with the benefits of DTG-based regimen, and you should also explain about the slight risk of possible neural tube defect in babies born to a small proportion of women who get pregnant while taking DTG. Even after explaining benefits and the risk of DTG, if a woman do not wish to take DTG-based regimen, alternative options such as efavirenz-based regimen should be considered. Next slide, please. Now, if the woman is already on DTG-based regimen and become pregnant, she may continue to be on DTG-based regimen and should be adequately counseled. All the newly diagnosed pregnant women, irrespective of the duration of pregnancy, should be offered DTG-based regimen as the preferred regimen. All women who are pregnant and not on DTG-based regimen, those females should also be shifted to the DTG-based regimen as soon as possible. Next slide, please. Now, the third is a toxicity which has been shown with the DTG is the weight gain. So weight gain was mostly seen in the patients who were on the backbone, ART backbone with the tenofovir, alfenamide with DTG. And this weight gain was shown to have more in the females, and that also with an African ethnicity. And the patients with a low CD4 and a high HIV RNA were more prone to have a higher weight gain. So still we need more data to have a clear view on the association of weight gain with the DTG. Next slide, please. Now coming to the renal insufficiency in patients on DTG-based regimen. So DTG can reduce the tubular secretion through inhibition of OCT2, that is an organic cationic transporter protein, which is present in your tubule and which is helpful in the secretion of this drug. So this can lead to the non-pathological and non-progressive increase in the serum creatinine with no risk of renal toxicity. And in these cases, you can just follow your patient on urinary protein and along with the serum creatinine. And patients with renal insufficiency, there is no dose adjustment for any of this INSTI, that is integrase inhibitors, and except on the days of dialysis, you are supposed to give this drug post dialysis. On other days, you can just continue a regimen as advised. Next slide, please. Now coming to the hepatotoxicity, no dose adjustment of DTG is required in hepatic insufficiency except in the Child-Pugh C criteria. So in Child-Pugh A or B, you can continue with your DTG-based regimen. Next slide, please. So what points you should keep in your mind while prescribing DTG? So adequate counseling on lifestyle and dietary changes for all the PL-HIV patients should be done. Measurement of blood pressure to detect hypertension with special attention to the risk of hypertension during pregnancy should be done. Then you should always monitor your patients and treat the metabolic complication, including the hyperglycemia and dyslipidemia if the patient develops on DTG-based regimen, and monitoring of weight and associated dyslipidemia and hyperglycemia for the toxicity monitoring of DTG should be always done. Next slide, please. Now coming to the other important drug, that is tenofovir. So tenofovir is commonly used ART and it has shown to have a relatively long half-life. So we prescribe it in the OD dosing. Usually it has a good overall safety profile with a fewer metabolic side effects. So major side effects of tenofovir, that is also associated with tenofovir is renal toxicity, which is seen in 3 to 5% of the cases, and decrease bone mineral density. So that is also seen with TDF rather than TAF. Next slide, please. So renal toxicity. So tenofovir can cause renal impairment characterized by increase in the serum creatinine with or without proteinuria. So pattern of kidney injury which has been seen with tenofovir is either acute kidney injury due to acute tubular necrosis. The patient can land up in Fanconi syndrome. So what is Fanconi? So the patient can have a normoglycemic glycosuria. Patient can have hypophosphatemia with hypokalemia and hypouricemia, and proteinuria with aminoaciduria, and patient might present to you with CKD if he or she is on tenofovir based regimen and his renal functions were not monitored. Next slide, please. Now, what are the risk factors for development of renal injury in the patients on tenofovir? So if the patient has already some risk of getting a renal injury, so that can be either the patient was on concomitant use of boosted PIs, or the patient was on some other nephrotoxic drugs. If the patient has some other reason for getting a chronic kidney disease like diabetes mellitus or hypertension or advanced HIV infection leading to HIV nephropathy, so these are the other risk factors for the development of kidney injury due to the TDF based regimen. Next slide, please. Now, how you can prevent this nephrotoxicity? So avoid administration of tenofovir in the patient with baseline EGFR of less than 60 or elevated serum creatinine. And renal function and proteinuria should be monitored during the use of tenofovir every 3 monthly for the first year, and then 6 monthly after this. And monitoring of 24-hour urinary protein and blood sugar and urine sugar should be done in the patients on tenofovir, and more frequent monitoring may be appropriate for the patients with additional kidney disease risk factors. Next slide, please. So this was for the patients who are going to be started on tenofovir. Now, if the patient is already on tenofovir based regimen, so if he or she develops a confirmed GFR decline by 25% from the baseline or to a level less than 60 ml per minute, it is recommended to substitute alternative ART drug for tenofovir, particularly in those with the evidence of tubular dysfunction. So from the ART with which you are supposed to substitute tenofovir is abacavir based regimen. So you are supposed to change to abacavir based regimen. Lamivudine dose is to be adjusted as per creatinine clearance. So if EGFR is more than 30, you can give full dose of lamivudine. But if it is less than 30, then you have to adjust the dose of lamivudine also. Next slide, please. So spectrum of bone toxicity. So tenofovir can cause moderate bone loss as measured by the bone mineral density after the initiation of ART. And it has been associated with a small but significant increase in the fracture rate in the retrospective analysis study. As the hypophosphatemias occur in the patients of on tenofovir based regimen, especially in the cases of Fanconi syndrome. So patient can have osteomalacia secondary to tenofovir, and these patients mostly present with the bone pain. Next slide, please. So to summarize till now, so how you can prevent the ARVs related toxicity. So you have to discuss the potential side effects with the PLHIV patients of the drug and caregiver before initiation and during the early stages of treatment as a part of preparedness counseling. Differentiate any new clinical event after the initiation of ART from IRIS. Always assess the toxicity and grade its severity. The management of toxicity depends on the grade of severity. Offer support during minor and major adverse event, and ensure that the patient, that is the patient who are taking those drugs, should be familiar with the signs and symptoms of the toxicities that are serious and require immediate contact like Stevens-Johnson syndrome or hepatotoxicity, or the patient knows about the abacavir associated hypersensitivity reactions. Next slide, please. Now, so when you club out the adverse events, so as we have already discussed that acute hepatitis can occur with nevirapine, efavirenz, and rarely it can be seen with a zidovudine also. So how you are going to manage these patients? If the ALT is, you have to give the supportive treatment. If ALT is more than 5 times, then you are supposed to stop all the ARVs until the symptoms resolve. Nevirapine should be permanently discontinued and substitute the nevirapine with the most likely offending ARV drugs. So nowadays we are not using nevirapine, so that is not a big problem right now. But yes, you are going to see it with the other DTG and other drugs also. Next slide, please. Now, acute pancreatitis usually seen with stavudine. So if the patient, and it can be seen with the zidovudine also. So if the patient and lamivudine, so if the patient is having lipase and amylase elevation, you are supposed to stop ARVs until the symptoms resolve, and you may restart the ART with the change in the regimen, preferably excluding the drug which is having a potential role in the pancreatitis. Next slide, please. Now, lactic acidosis, all the NRTIs can cause lactic acidosis. So how the patient of lactic acidosis can present? It may present as simple generalized fatigability and weakness. The patient might have a GI symptom in the form of nausea, vomiting, diarrhea, or abdominal pain. The patient might land up in having a respiratory symptoms of tachypnea and dyspnea or neurological symptoms. So you are supposed to get an ABG if possible. And if you are and a serum lactate level, so if it is elevated and you are sure about lactic acidosis, discontinue all ARTs. Symptom may continue or worsen after the discontinuation of ART. So give supportive treatment and resume ART by replacing the offending ART with either abacavir or tenofovir based regimen. Next slide, please. I think we missed the last slide. So hypersensitivity reaction. So it can happen with abacavir and nevirapine. So if this is happening, you are supposed to discontinue all the ARTs until the symptoms resolve. You then administer the supportive therapy. Do not re-challenge with abacavir or nevirapine as the anaphylactic reaction and death have been reported. Next slide, please. Now, coming to the rashes. So rashes and drug eruptions, including the Stevens-Johnson syndrome and TEN, has been reported with the nevirapine and efavirenz, and rarely with DTG and lamivudine. So in mild cases, you are just supposed to give the antihistaminics. If the rash is moderate, non-progressive, and without mucosal or systemic symptoms, consider substituting nevirapine to efavirenz after the rashes resolve. In moderate or severe cases, discontinue all the ARVs until the symptom resolve and give supportive treatment. If the patient has developed systemic symptom like fever or severe rashes with mucosal lesions or Stevens-Johnson syndrome or TEN, permanently discontinue nevirapine and switch to ART regimen to different ARV class that you can just choose 2 NRTIs with a protease inhibitor. Next slide, please. Now, diarrhea. So lopinavir, ritonavir has shown to have diarrhea. So usually it is a self-limited condition and you are not supposed to change to other regimen. But in cases if diarrhea is not controlled, you can change it to atazanavir, ritonavir combination. Now, dyslipidemia, insulin resistance, and hyperglycemia. For that, you may replace to a PI which has shown to have a lesser risk of metabolic toxicity. Next slide, please. Now, GI tolerance is usually self-limited, and you just need to provide symptomatic treatment. For a hematological toxicity, it is seen with zidovudine, and if the hemoglobin is less than 6.5 or the ANC is less than 500, you are supposed to stop zidovudine and change to tenofovir or abacavir based regimen. And for the supportive treatment, you may consider for the blood transfusion. Next slide, please. Lipoatrophy, lipodystrophy, usually seen with the stavudine, which we are not using now. So in few cases of protease inhibitors or in patients on zidovudine, you can have it. And in those cases, you are supposed to change it to tenofovir or abacavir based regimen. Next slide, please. Now, neuropsychiatric symptoms seen with efavirenz, and the patient may come with confusion or abnormal thinking. So in those cases, usually it is self-limited, no need to discontinue the drug until severe psychosis is there. And you are supposed to tell to your patient to take efavirenz at the night time. In the cases of renal toxicity, that is tenofovir induced, you are, as we have already discussed in detail, that you are supposed to stop tenofovir and change it to abacavir based regimen. Next slide. Now, if the patient is having drug eruption or rashes, including Steven Johnson or 10, so usually it is seen with nevirapine or nevirapine, but it may be seen with the cotrimoxazole also. So there are sporadic reports on skin rashes induced by zidovudine, lopinavir, and ritonavir, and including DTG and lamivudine also. So the most important thing is to identify the offending drug so that you can stop that drug, and then you can make a regimen excluding that drug. Next slide. So this is an algorithm for the patients who develops rashes after on TLD regimen. So what you can do if the patient is with cotrimoxazole prophylaxis, first you have to change it to TLE without cotrimoxazole. So if tolerated, you confirm it with a DTG. As a case of DTG hypersensitivity, you continue with the TLE based regimen and introduce cotrimoxazole if indicated. If rashes reappear, you suspect that either it is because of tenofovir or lamivudine. So you stop all ARVs, and once rashes subside, you start with tenofovir and lamivudine for 7 to 10 days and observe. If rashes reappear, confirm it is either because of tenofovir or lamivudine, and you stop all the ARVs and give only monotherapy of tenofovir for 7 to 10 days and observe. If rashes reappear, confirm it to be tenofovir induced drug rash, and you start the new regimen with an abacavir lamivudine DTG. If rashes do not appear, confirm to be lamivudine induced and start the new regimen with the tenofovir, zidovudine or DTG. Next slide, please. Now, coming to the grading of drug toxicity. Next slide. So the grading, the ARV drug toxicity has been classified into 4 classes. So it can be either grade 1 mild, grade 2 moderate, grade 3 severe, and grade 4 potentially life-threatening. In addition with the of grade 5 toxicity, which is death. Next slide. So mild grade, that is grade 1, that's the symptoms is not causing any interference with the usual social and functional activities. Grade 2 includes greater than minimal interference. Grade 3 causes inability to perform usual social and functional activity, and grade 4 are the symptoms using inability to perform basic self-care, or you need to have a medical intervention for the relief of that symptoms. Next slide. Now, if the patient is having a mild to moderate ARV drug toxicity, no need to change the ART. So you can just observe your patient. If the patient develops grade 3 toxicity, it is usually necessary to discontinue the suspected drug until the condition resolves. Subsequently, you may consider to re-challenge with that drug. But in the grade 4 toxicity, discontinue all the drugs, hospitalize the patient, and the offending drug should never be re-administered. Next slide. Now, coming to the grading separately. So if the hemoglobin is less than 6.5 and it is and your patient is on zidovudine based regimen, don't re-challenge with zidovudine. If the ANC is less than 500 or the platelet count is less than 20,000. So, and if coming to the hyperbilirubinemia, if it is more than 5 times the upper limit, don't reintroduce your atazanavir based regimen. Then a fasting glucose more than 500, or your patient is developing hypoglycemia less than 30, change the drug. Next slide. If the patient is having triglyceride level more than 1200, if OTPT is more than 10 times elevated, never re-challenge with that drug. Then if the patient is having pancreatic amylase level elevation more than 5 times the upper limit, never reintroduce that drug. And if the patient is having elevation in the serum lactate level with the pH less than 7.3, then you are supposed to never reintroduce that ARVs. Next slide. Now coming to the dyspnea. So if the patient is having nephrotic, patient is having dyspnea which requires oxygen supplementation, so never reintroduce that drug. That is mostly abacavir or nevirapine. And if the patient is having nephrotic range proteinuria, that is more than 3.5 gram loss of protein in urine per day, then don't give your tenofovir. Next slide. Now coming to the miscellaneous. So fever more than 105°F, intractable headache, or rashes including 10 or Steven Johnson syndrome. So these are the grade 4 toxicities. So never re-challenge with that ARV. Next slide. So drug substitution. So there, as you all know, that substitution is different from switch. So what is substitution? Substitution refers to the replacement of ARVs in PLHIV, which you are doing because of any adverse drug reaction, and you are just changing that drug with the same group of ART. Okay, and delaying substitution may result in severe drug reaction. And when you do the switch you do in the cases of treatment failure, and it is usually done if you are thinking that there is a loss of antiviral efficacy to the current regimen, and that's why you change to the second line or third line ARTs. Next slide. So zidovudine, if the patient is having zidovudine induced toxicity, you can change it to the tenofovir based regimen. If the patient is having abacavir hypersensitivity reaction, you may change to tenofovir and or zidovudine if tenofovir is contraindicated. Now, if the patient is having tenofovir induced renal tubular dysfunction, or the patient is having osteoporosis secondary to tenofovir, you may go with an abacavir based regimen. If the patient is on efavirenz and he or she is developing severe psychosis or efavirenz related Steven Johnson syndrome, you may go with the DTG based regimen. Next slide. If the patient is having toxicity of both efavirenz and nevirapine, then you may go with the DTG based regimen. If the patient is getting hepatotoxicity or secondary to DTG, or if the patient is female and she doesn't want to conceive on DTG, so you can provide them a efavirenz based regimen with appropriate 2 NRTIs. In example, you may go with the tenofovir, lamivudine, efavirenz, or ZLE. Now coming to atazanavir, ritonavir toxicity, if the patient is intolerant secondary to hyperbilirubinemia or hyperglycemia, you have to go with a DTG based regimen. And if the patient is having toxicity of multiple NRTIs, then you may choose with a DTG in combination with an appropriate boosted dose of protease inhibitor. Next slide. Now, in the cases of hepatotoxicity and hypersensitivity reaction, in cases of DTG, if the patient is on DTG based regimen and the patient is having hepatotoxicity, and then you are supposed to substitute with the other therapeutic classes, and you may choose with efavirenz or boosted PI. In the cases of insomnia, especially the risk factors, insomnia is seen in the patients who are elderly. So you may monitor your patient, or you may consider morning dose or substitute to efavirenz, boosted PI or altegravir based regimen. Then in the cases of weight gain, you may monitor body weight and promote anti-obesity measure, like you can ask your patient for the lifestyle modification, and proper diet counseling should be done. And if there is a significant increase despite these measures, you may consider substituting to efavirenz or boosted PI. Next slide. Now, if the patient is on is developing renal dysfunction, so the preferred drug regimen will be abacavir, lamivudine, DTG with a dose adjustment of lamivudine according to the creatinine clearance. So if the patient is having creatinine clearance of more than 30 ml per minute, so you can give full dose of abacavir with lamivudine. And if the creatinine clearance is less than 30, and if you are not having lamivudine single tablet of 100 milligram, you may give full dose of abacavir lamivudine, provided you do the close monitoring of the renal function with the repeated test. And in case if the creatinine clearance worsens, then the ART must be stopped and the cases must be referred to a COE for the SASAP opinion. Next slide. So to summarize, the general principle is single drug substitution for the toxicity should be made within the same ARV class. If a severe or life-threatening toxicity occur, all ART should be stopped until the toxicity has resolved, and a revised regimen should be started when the patient has recovered. Whenever an ARV toxicity is suspected, rule out other OIs or other condition that may be responsible. Always grade the toxicity according to the severity. For the patient with a dual toxicity to nevirapine and efavirenz needing substitution with the PIs, these PI-based regimen must be started by a COE or ART plus center after the review and approval of ESASAP. Next slide. Okay, I think that much is from my side. Thank you. So if anyone has any question.
Thank you, ma'am. I'll just check the chat box. Meanwhile, participants can also unmute their mic if they have any questions.
So I can just see there is a question, a chronic alcoholic or a patient with a markedly raised LFT, SGOT-PT greater than 250 units, but no symptom. Should TLD be started, or if already started, should the patient be continued with the TLD? And should INH prophylaxis can be given in those cases or not? CLD. So if a patient is if the patient is just a chronic alcoholic, but there is no evidence of CLD, then you can give INH prophylaxis. And for ART regimen, I think you may start with the TLD based regimen with a close monitoring of transaminase levels.
Yeah, I would like to add something to it. If somebody is having acute hepatitis, you can just wait for 15 days, take a gastro opinion, because you can always give steroids to alcoholic hepatitis also. So we just wait. And if it is a decreasing trend, we will wait till the patient's OTPT is normalizing. But if the patient's OTPT is not normalizing, then we can start with very, very close monitoring. But first we have to see whether there is some acute hepatitis or not. In acute hepatitis, we would like to wait till everything resolves.
TI of TLD and TLE with the drug interaction of TLD and TLE with buprenorphine. We need to see that. I think with the TLE, so you should always avoid this drug buprenorphine, because already the patient is having a higher risk of getting a neuropsychiatric manifestation. And for TLD, I have to check it first. Meanwhile, you can just ask any other question if anyone wants to.
Hello, ma'am. Good afternoon.
Good afternoon.
Ma'am, you just mentioned the elevated serum creatinine level.
Yeah.
So I just want to know how much the level we should take into consideration before switching it to the ABC.
You have to monitor it with the EGFR. So yeah, the elevation of serum creatinine, I think voice is echoing.
Yeah, maybe you have logged in from two systems. That's the reason, ma'am.
Hello?
Yeah, there's still an echo. Vishal sir, you'll have to log out.
Okay, madam.
So you have to calculate EGFR for those patients. A healthy patient who is having a weight of 70 or 80 kg with a creatinine of 2, I'm not worried. But if the creatinine is 1.5 and the patient is lean and thin with a weight of 30 kg, so you have to calculate EGFR, and then you have to decide that whether you are supposed to discontinue or continue your tenofovir based regimen.
You just mentioned two things, EGFR as well as the serum creatinine level. I mean,
so obviously for the calculation of EGFR, you need a serum creatinine, then that's only you can calculate. Okay. So there's no absolute cutoff for the serum creatinine. It's just for the EGFR.
Okay, thank you.
Welcome.
You just mentioned one thing, the rest we are encountered with the rest still occurring with the TLD use. And myalgia is such a very common symptom that the PLHIVs are presenting with.
With
So
DTG based regimen.
Yeah.
It may be, it can be because DTG is also an integrase inhibitor, but raltegravir has shown to have a more association with myalgia and your myalgias especially as compared to DTG. So for that, too, we need a more level of evidence and more close monitoring.
Right, ma'am. Thank you.
Maybe there's depression.
Ma'am, there's a question in the chat box. If has bilirubin more than 5 of
PLHIV on atazanavir and he is asymptomatic, does it need substitution? So first, before substituting, which I wanted to highlight, that you have to just see that what other drugs the patient is taking and what is the cause of that hyperbilirubinemia. So if it is just related with the atazanavir and the bilirubin is more than 5, then you are supposed to wait and closely monitor. And if it is persistently elevated more than 5, then you are supposed to change it.
Usually we wait till if the SGPT and SGOT is also raised, then we usually stop and change to adalopinavir or ritonavir. But other than that, if it is just indirect hyperbilirubinemia, we have continued in many patients and they do well. They don't have any problems. So usually atazanavir causes.
I think the better will be you take a opinion from SASAP and COE.
So we just wait. In indirect hyperbilirubinemia, just due to atazanavir, I don't think so 5 is the only cutoff. But if the patient has CLD or the SGOT and SGPT is raised, then we would take we take another decision depending upon what other comorbidities or whether the patient has CLD or not.
Thank you, ma'am. Any more questions from the participants? Please feel free to unmute your mic. किसी को कोई सवाल पूछना है? Ma'am, I don't think there are any questions.
Okay then. Okay,
Yeah.
thank you.
Thank you so much, ma'am, for facilitating this session. Thank you, Jaya ma'am, for joining us.
Thanks
Thank
from
you.
Jaya ma'am also.
Yeah. We
Okay.
quickly run the feedback poll.
Okay.
The feedback poll is now visible on your screen. Participants are requested to please attempt all the 4 questions.
Chat box में डाल देते हैं. Trimethoprim does not have any interaction with tenofovir. और bilirubin, Insomnia and this one will go to the-
Ma'am, there's a question in the chat box.
No, I can't find.
Yeah, I'll just read it out, ma'am. Buprenorphine does not
That-
have any drug interaction.
That I have replied
You
that,
have
yeah, so, yeah,
Okay.
there's.
Okay. Yeah, we'll end the e-poll now. Feedback submitted.
Hmm.
Thank you to all the participants for patient listening. Ma'am, can we conclude the session now? Oh, you're on mute, ma'am.
Yes,
Yeah,
we can.
thank you so much,
We can
ma'am.
finish the session. Okay, thank you. Okay, bye.